Good afternoon. I am Jennifer Rowe, a medical student at the University of Ottawa. Today, I am presenting on implementing a teleteaching and mentorship program, Project ECHO, to build pediatric palliative care capacity, the evaluation of a Project ECHO on pediatric palliative care targeting health professionals in South Asia, and exploring learners' perspectives of a pediatric palliative care telementoring and education program. Our fantastic team members are listed here. First, I want to provide some background about our program and studies in this area. Every year, more than 40 million people around the world need palliative care to address their pain, physical symptoms, as well as emotional, social, and spiritual needs. 78% of these individuals live in low and middle income countries where access to palliative care can be extremely limited. For children, the need for palliative care is even more concentrated in resource-limited settings, with 98% of children with life-limiting conditions living in these areas. As you can see from this chart, children may require palliative care for a wide variety of conditions. Globally, the most common conditions include congenital anomalies, neonatal conditions, and HIV/AIDS, which reflects the lack of access to potentially curative treatments in many countries. Of note, cancer makes up less than 10% of the pediatric palliative care population. You will also notice how much these groups differ from the adult disease groups. The World Health Organization provides guidance about the key measures to assist countries seeking to implement palliative care. These include education, government policy, and ensuring access to opioids. I want to focus on education, since a lack of knowledge and skills in palliative care has been identified as a significant barrier to improving its availability, specifically in low and middle income countries. In these settings, teaching on palliative care and pain management, particularly the use of opioids, is not systematically incorporated into undergraduate training programs for physicians or other healthcare professionals. Additionally, myths about morphine and the risk of addiction are common among doctors and other healthcare providers, which then prevents patients from accessing these treatments. This led our team to the question of how we, in Canada, can support collaboration and knowledge sharing. These images show a palliative care nurse educator, Swaroop, who was able to come to Canuck Place Children's Hospice in Canada to learn more about pediatric palliative care. This is a great way to strengthen knowledge, but we cannot do this for every healthcare provider living in a resource-limited setting. So, recognizing these barriers, we formed a team of dedicated palliative care experts and supporters from Canada, India, Nepal, and Bangladesh. These leaders have come together to develop a virtual learning program to improve pediatric palliative care capacity in South Asia. Project ECHO is an online technology-enabled education model that develops a learning community and provides teaching and mentorship to participants. The main partners are shown in our logo on the left: Two Worlds Cancer Collaboration, a Canadian NGO, the Hyderabad Center for Palliative Care in Hyderabad, India, and the PRPCS, which is the Pain Relief and Palliative Care Society, also in Hyderabad. Project ECHO is a global educational movement, originally developed in New Mexico, to reach rural patients needing hepatitis C treatment. Since then, it has grown to 960 programs in 45 countries. ECHO stands for Extension for Community Healthcare Outcomes. In our Project ECHO, we use internet-based video conferencing to connect learners at spoke sites with pediatric palliative care experts at a hub site and internationally. ECHO emphasizes moving knowledge, not people, having the training reach healthcare professionals where they are, instead of requiring them or their patients to undertake long journeys to specialist centers to receive training or care. This is particularly beneficial in resource-limited settings, where larger outreach results in a greater number of learners, further leading to increased availability of palliative care for patients. Over the past 3 years, we have implemented 8 ECHO courses, ranging between 7 and 27 sessions. We have reached clinicians in 6 countries, with more than 350 participants joining almost 100 sessions, and we can continue to grow our outreach. We encourage and invite participation from a wide range of disciplines, including nurses and physicians, as well as counselors, social workers, psychologists, physiotherapists, and pharmacists. This results in interdisciplinary collaboration and creative solutions to support patients and families. Depending on the ECHO course, we target specific groups of learners, including those you see listed here. Now, I would like to share our experiences with implementing these programs in resource-limited settings, including a few key challenges and adaptations that our programs benefited from over time. We learned in our first year that session timing is critical. For South Asia, the sessions must be either before or after work, as our medical practice isn't structured in a way that allows them to stop during the day. This was a large barrier for many participants. Additionally, defining your learners is important. Utilize a narrow scope. For example, pediatric oncology professionals in Nepal. You can then recruit participants by word of mouth, mobile phone, text messages, or emails using professional networks. In our case, we use partnerships with the Indian Association of Palliative Care and the Nepalese Association of Palliative Care to reach potential participants. We found that we needed to understand our participants, particularly their length of session preference and timing, their learning needs, and their preference of communication. We created simple surveys using Google Forms that are quick and easy for participants to fill out on their mobile phones. We found participants were commonly using mobiles to access the internet rather than email. Therefore, we communicated by means of WhatsApp or Facebook. Meeting their need is key to continued participation. There are several critical barriers which need to be considered when implementing virtual training, specifically the lack of face-to-face interaction, while balancing the traditional teacher-learner hierarchies in South Asia. To overcome these challenges, we found it was important to have a highly approachable and engaged faculty with local members of the palliative care community as well. Additionally, in low and middle income settings, we need to ensure that the content is relevant to the local audience and their healthcare situation. Participants find it frustrating to have teaching be focused around medications or treatments which are unavailable or unaffordable in their setting or region, or do not reflect the cultural realities of their work, which is particularly relevant in a palliative care setting. Our faculty would encourage learners to critically appraise the new material and think of ways to incorporate it into their clinical practice within a resource-limited setting. ECHO emphasizes active learning, which leads to deeper learning and implementation in clinical practice. It is particularly challenging to evoke active participation in an online setting. So to do this, our ECHO training must then be interesting and engaging. We used our faculty to draw in the learners into the discussion. We also found it critical to have a skilled session facilitator. So we developed a program to train our facilitators once we identified what elicited participants' interaction in our sessions. The key elements that we found included posing questions or providing polls and discussing the results, asking those who are active in the chat to discuss verbally, and encourage the use of the chat for those who are more shy or nervous, possibly due to language barriers. Sharing personal experiences within clinical settings was also very beneficial. Over the past 3 years, we have realized that the live ECHO sessions are only one component of our work, and that we can enhance the information from the live ECHO sessions and extend our outreach by creating a larger learning community. Our community allows participants to connect between and beyond the individual sessions. As an example, I've shown a screenshot from the WhatsApp group of one of our recent ECHO programs. In this group, we share the weekly Zoom link and session topic, as well as links to other videos or resources which might interest participants. They are encouraged to share questions or cases which are challenging and can seek advice and support from other practitioners, as well as faculty expertise. Another aspect of the learning community is maintaining a resource library, which we do via Google Drive. Here, we share all the presentations as well as free textbooks on palliative care, guidelines, journal articles, and more. Additionally, we record all the sessions and upload them to a private YouTube channel, which allows participants to rewatch sessions or share the recordings with their colleagues. We also encourage them to use the sessions for their own teaching. We did find it was really important to organize videos by date and title so that participants can quickly find the relevant video. It does require diligence from one team member to ensure things stay organized on all platforms, including email, WhatsApp, YouTube, and the Google Drive. Finally, a key component of ECHO is developing diverse leadership teams, which bring together both local, regional, and international experts and partner with local and regional organizations. The image shows the leadership team and partner organizations from our recent ECHO series in Nepal. This ECHO team included established leaders and key stakeholders from Nepal, supported by palliative care experts from India and Canada. The local leaders are key to ensuring that the course is practical and supports practice change for participants. For example, local leaders know which medications are easily available and affordable for patients. Involving these local leaders also provides them with an opportunity to learn from established ECHO leaders, with the goal that they can then go on to run their own local ECHO courses in the future. And we have developed a training program to help local leaders build the skills in leading their own individual ECHO programs. For the third and final part of this presentation, I would like to describe the components of the program evaluation, including how we successfully integrated program evaluation and explored participants' learning experiences. From 2017, when we first started to plan our ECHO, we discussed how to implement the sessions, conduct research, and perform program evaluation. Our evaluation consisted of two parts: a quantitative component, which included surveys of participants before, immediately after, and 6 months following a course. The second was a qualitative component, since we felt that this would likely lead to more detailed and nuanced information about the experiences that participants had. The study had a number of aims. Quantitatively, we wanted to measure the use of learning materials and how well these matched the learning needs of participants. We also looked at participants' self-efficacy, attitudes about palliative care, and their comfort with providing pediatric palliative care. The qualitative component then focused on broad exploration of learner experiences. This included their motivation to join and stay in the program and their learning outcomes. We also wanted to explore the extent of the community that was created, the impact of ECHO on clinical practice, and personal benefits that arose, such as resilience. I will share a few of our findings from the first ECHO program. Here, you can see the participants in terms of their professional role. Most are physicians. There's a wide range of clinical experience and number of patients each practitioner cares for. We had similar findings in the subsequent courses as well. We find that there's a wide range of participants who are attracted to participate and then stay in the subsequent programs. We found this information particularly interesting, as a recent study of a PPC ECHO program in Canada had reported improvement in participants' comfort and self-efficacy. Here, when we looked at participant comfort levels providing palliative care, it did not improve significantly for most of the items, although, as you can see, breaking bad news and providing bereavement care improved more than others. We further explored these changes through focus groups, interestingly identifying several themes. I will expand further on these findings later. Participant attitudes were also only slightly improved through participation, although positively impacted. Through the focus group interviews, patients had endorsed much improved knowledge on the topic and clinical practice of providing pediatric palliative care. We think that participants lacked knowledge of pediatric palliative care when beginning the course, so they were not necessarily aware of what they didn't know, which may have limited our ability to detect significant changes. Now, I would like to share some of the qualitative data, which explores learners' experiences more broadly, elicited through the previously discussed focus groups. Focus groups participants were recruited from those who had attended at least 5 sessions out of a total of 24. Participants were 71% male and almost 60% were from India, with the rest from Bangladesh. Most were physicians, which was similar to the participants in the program at large. The participants were from a variety of different practice settings, including rural services, hospitals, hospices, and home-based palliative care systems. I will outline some of the key themes identified from these groups. One of the frequent themes across the focus groups was the sense of community and the opportunity for collaboration that was created by our program. Becoming members of an international learning community was a very meaningful aspect for most of the learners. They expressed that they would like to create more permanent collaborating relationships. While the program was running, they also constructed additional learning communities at their own health facilities, stimulated by participation in the ECHO program. Through these, they shared resources and clinical experiences with their fellow physicians or staff members. Participants identified a significant benefit being the unique ideas and experiences shared by different learners, as our program provided a platform for sharing ideas from across a wide range of resource levels, cultures, and palliative care settings. They also noted the importance of the international group, as members from different countries provided new perspectives and different approaches to clinical scenarios that could then be adjusted to meet cultural expectations. Participants also identified the importance of gaining new knowledge and skills relevant to pediatric palliative care, specifically those related to their own self-identified knowledge gaps. Areas that were found to be challenging, such as communication with children, were highlighted as very valuable skills that were improved through our ECHO sessions. Beyond the benefits of the knowledge itself, participants also noted reduction in stress, as ECHO PPC provided them with clinical skills and strategies to better address their patients' needs. It is important to note that participants felt barriers related to the language challenging their ability to communicate their knowledge or to engage fully in the sessions. A reluctance to speak in the group setting due to shyness or for fear of not being understood was expressed through these focus groups. They also noted reluctance to ask questions, which was often related to cultural barriers. This may be particularly relevant in South Asia, where cultural norms would include not questioning teachers or experts. These quotes highlight one of the participants who shares resources with their fellow practitioners after translating the information. In summary, Project ECHO suggests a novel and emerging model of building pediatric palliative care capacity, which can be adapted to provide education to healthcare providers in low and middle income countries. Key adaptations of the program are summarized above. These include addressing the challenges of virtual learning and being aware of socio-cultural differences when working with educators and leaders in both higher and lower resource settings. It is important to plan for recruitment and retention of participants and specifically understand the learner's needs, including creation of a virtual community that exists outside of the sessions alone. Facilitators are critical in creating the bridge between participants and faculty and aid in a supportive learning community. And when developing an ECHO program, it's very important to highlight the critical need of this role. Lastly, our evaluation of participants' experiences revealed that they value learning within that supportive learning community. Specifically, sharing of ideas and experiences was very meaningful for them. Challenges of time and sociocultural factors should always be considered. This is where those facilitators should always be encouraged to address the cultural and resource differences in medical care within different resource settings by making suggestions and stimulating discussion about how to adapt treatment plans or treatment suggestions from high-income settings to be useful within local resource constraints. Thank you.